Hello, everybody, and welcome to the Pediatric TB Radiology It's Not Black and White Part 2 webinar. My name is Amelia Alanis. I'm a program manager at the Curry Center. Today we have over 300 participants joining us from across the U.S. Today's session is being recorded and will be archived on our website. Please look out for an email announcing when it has become available in 2 to 3 weeks. You have all been placed now on mute in order to preserve the quality of the recording. If you have any questions or comments during the webinar, please feel free to share them in the chat box. The faculty may address some of the questions in real time. There will also be an additional 15 minutes for Q&A at the end of the presentation. If you are listening via the phone, please enter the code provided to you within the Adobe Connect to link your phone and your computer if you haven't already done so. This code will be automatically displayed to you if you selected the phone option on the audio menu. It can also be located by clicking the lowercase letter I in the upper right-hand corner. This can help us manage any audio problems that may arise. This webinar is produced by the Curry International Tuberculosis Center, which is part of the University of California, San Francisco, and is located in Oakland, California. The Curry Center is one of 4 TB Centers of Excellence for Training, Education, and Medical Consultation. CITC covers the western region of the United States, which consists of 17 jurisdictions pictured in purple on this map, plus the U.S.-affiliated Pacific Islands. This project was funded by the CDC's Cooperative Agreement and is a project of the University of California, San Francisco. The Curry Center is accredited by the ACCME to provide continuing medical education for physicians. The Curry Center is also an approved provider of continuing education by the California State Board of Registered Nurses. This webinar is approved for a total of 1.25 continuing education contact hours. To receive your continuing education contact hours, you must have registered for the webinar, participated in the entire training, and complete the online evaluation. The web link for the evaluation was emailed to all registered course participants this morning. We ask that you complete it within 1 week. Pre-registration is important so that we can ensure that we don't exceed the capacity of our Adobe Connect webinar system. However, as mentioned on an earlier slide, if any individuals or group members have not pre-registered, please enter their full name and email in the window below or in the chat field so that they can receive the evaluation link, be eligible to receive CMEs or CNEs, and so that we can document their participation. For those who complete all the required steps, your CME and CEU certificates of participation will be available on the Curry Center website within 12 weeks. Today's faculty have signed a declaration of disclosure and have indicated that they have nothing to disclose. It's my pleasure to introduce to you the faculty for today's webinar, Dr. Ann Loeffler and Dr. Tien Khai Vu. Dr. Loeffler and Dr. Vu will introduce themselves and facilitate the rest of the webinar.
Hi everyone, good to be here with you this morning to talk about pediatric TB radiology. My name is Tien Khai Vu. I go by Khai. I'm an associate clinical professor at UCSF. And it's wonderful to be here once again. Okay, go ahead, Ann.
Good morning. I'm Ann Loeffler. I'm a pediatric infectious disease doctor, and I work in Portland, Oregon at Randall Children's Hospital Legacy Health, and have been working for the Curry Center as our pediatric TB consultant for 20 years. So very excited to do these ongoing trainings, both in person and in webinar, and especially excited to have my second collaboration with Dr. Vu, who is an amazing radiologist, and I hope you all learn a lot from him today. If you have questions after today's conference about any clinical pediatric TB question, you can always reach me through the Curry International TB Center warm line, which you can find on our website and access either by email or by phone. I think email is easier. So I think first this morning, we are going to have a very exciting and informative run-through of pediatric radiology focused on tuberculosis by Dr. Vu. And after that, we'll go over some pediatric cases that we experienced right here in Portland, Oregon. You probably don't think of Oregon as a hotspot of pediatric tuberculosis, but we get a good handful of cases, and sometimes they give us a run for our money. So we'll need Dr. Vu's background so we can help interpret these films.
Okay, everyone, so this is our learning objective. I'm not going to read them because you have access to them, so we can go ahead and proceed in the interest of time. So with regard to pediatric radiology, I think the hardest image to interpret is in a neonate. So here's an example of a normal neonate, and what makes it difficult is that the mediastinum structures are very prominent because the thorax is small. So in this case, of a normal neonate, the heart can be artificially enlarged, and the cardiothoracic ratio can be up to 0.65% as compared to 0.55% in an adult. Similarly, another structure that's very prominent in a newborn is the thymus, as outlined here. Now, the thymus also have a number of configurations that can also mimic adenopathy sometimes. Here's an example of a right-sided thymic cell sign. The cell sign can also occur on the left, as clearly seen here. The thymic cell sign can also mimic pneumomediastinum. In this case, it could represent the angel wing, the angel wing sign, but this is a normal thymus. So remember that. The thymus can also mimic atelectasis, as in this case, the thymus is appear to pull the trachea over to the right, mimicking atelectasis. Additionally, on the lateral, which we need to evaluate adenopathy in a young patient, the thymus can also occupy the area just above the minor fissure, mimicking consolidation or atelectasis. And this is the sign that I love the most. This is a wave sign, thymic wave sign, and it's really a very large thymus pushing against the rib cage. Now, as the child grows, the cardiomediastinal silhouette is going to change, including the thymus. And so here's a 14-month-old child. It's a 2-year-old child. It's a 3-year-old child. And as you notice, the thymus area is getting smaller and smaller. And finally, in a 9-year-old, you hardly see the thymus at all, although the weight of the thymus is continuing to increase, even though the size is getting smaller. Let's move on to pediatric TB chest findings. The most common findings in pediatric TB chest findings are atelectasis consolidation and adenopathy. The next set of findings are bronchial narrowing, nodule, lung hyperinflation, and very rarely we will see pleural effusion. So here's a few studies looking at the various findings in pediatric TB. And as you can see, mediastinal adenopathy is very common almost across most of the series, and then consolidation is next. Okay. Similarly, with regard to CT findings, the adenopathy and consolidation are very similarly very common findings on CT as well. So here's a great case of a 2-month-old with TB. This particular patient has all the findings. So now the patient is fairly rotated, so it's hard to see the consolidation. But here's an example. Yeah, right. So here's the example of the consolidation. The patient also has diffuse lung nodules, and the adenopathy is very difficult to visualize. Now, in the same patient, and the X-ray is repeated, where the patient is no longer rotated, you can see the consolidation very well. You can see diffuse lung nodules. Again, adenopathy is very difficult to evaluate on a frontal chest radiograph in a young patient. Hence the lateral. Now, on the lateral, you can see the consolidation once again, and this is the region where you want to evaluate for adenopathy. Here's the trachea coming down. Anteriorly, you have some normal vascular structure, but in this case, you can see a lot more opacity than the normal vascular structure. So there's suggestion of adenopathy here. This is a CT of the same patient. Here is the adenopathy seen on the lateral chest radiograph. Here's the atelectasis mimicking consolidation. And here's the actual consolidation itself. The same patient in lung window, you can see that this patient has diffuse lung nodules, suggesting disseminated TB. Now, when you approach an older child, it's good to evaluate, good to have a systematic approach to interpretation. So firstly, you want to evaluate the cardiomyostinal silhouette. You want to evaluate the airway structures for strictures. Then you want to evaluate the hilar region. Now, the hilar region, to me, the most important thing is to evaluate, when you evaluate the hilar structure, is the vessel. And you should remember that the vessel should taper, very much like the two carrots that I drawn in here. Now, let's move on to evaluate a few cases using our systematic approach. On this frontal chest radiograph, you can see that the hilar region is not tapered like a carrot, like what I just showed you. It's very bulbous, looking more like potatoes than carrots. Here's the lateral to confirm. This is the potato that I just discussed, suggesting adenopathy rather than a carrot. Now, when you evaluate higher up above that, you have to be sure that you evaluate the pulmonary artery and not to confuse that with adenopathy. So this is the right pulmonary artery, and this is the left pulmonary artery in the back. So those two structures should be in your mind when you evaluate adenopathy, particularly near the airways on the lateral projection. Here's another case of a 34-month-old TB patient. Again, the vessel does not taper. You can see that there's a rounded opacity projecting near the hilum. Additionally, this patient also has small nodule that's being obscured by the heart border. So make sure, when you look at the chest radiograph, make sure you look over the heart, and normally you should see branching vessel, but if you see additional finding, consolidation nodules, then you should get the lateral to evaluate. So here's the lateral of this same patient. You can see that this patient does not have the right upper lip bronchus. The right PA is being obscured by this large area of opacities, and then the left PA is also being obscured. So this is a large amount of adenopathy in the hilar region, likely on the right. And then looking more inferiorly in the lung, you can see that the patient has small nodules in the left lower lobe, as seen on the frontal chest radiograph previously. Here's a patient, 6-year-old TB patient, and once again, looking at the hilum, you can see that this hilum does not taper like a carrot. You can see that there's an opacity projecting very near that right hilum. Additionally, the patient also have area of small nodule in both upper lungs. Here's the lateral of the same patient. You can see that this is the region of the left PA, but it's more rounded than what the left PA should be, so there's a suggestion of adenopathy in the left hilum there. Here's the area of consolidation seen in the upper lungs. This is a 7-year-old patient with TB. Here, the hilum is very irregular. You can actually see consolidation or opacity right here above the hilum. And then at the hilar region, you can see that it's a little bit denser. That's also a sign for adenopathy. And more inferiorly, you can see that the patient also has distal small nodule in the right lower lung. Again, this is the lateral of that same patient. This is the right oblobronchus, the airway. So you look anteriorly for the right PA, and you can see the right PA is there, the left PA is there. But overall, the density has slightly increased, suggesting mild adenopathy in that region. And more distally, you can see small nodule size consolidation in both the right middle and lower lungs, as well as the right upper lung. This is the CT of that same 7-year-old patient. Again, you can see that there's an anterior adenopathy, which we not able to see, although in this case, the differential also includes prominent thymic tissue, which I think in this particular case, I think it's a combination of thymic tissue plus some adenopathy there. Here's the region on the right hilum, and you can see that it's quite irregular. There's some adenopathy in the right hilum. Further down, you can see additional adenopathy in the right hilum. And in the lung window, you can see the patient has small nodule in the right upper lobe. Further down, you can see some consolidation in the anterior right upper lobe. This is an older patient, 15-year-old TB case. And when the patient is this old, they start to present like adults. You can see cavities on the right middle lung there. You can also see right hilar adenopathy. And then on the lateral, you can see dense adenopathy overlying the right PA. Above that, you can see a small cavities. Now, let's go back to a young patient. This is a 12-month-old patient. This is a very large loculated fluid effusion pushing on the lungs. Additionally, there are consolidation in the lungs. Is it TB or not TB? Remember, fluid effusion is fairly rare in primary TB with regard to young patients. So this turned out to be MRSA and not TB, MRSA and empyema. With regard to TB fluid effusion, very uncommon. It's an uncommon finding in children. And tuberculosis fluid effusion are rare in young children, but are most frequent in adolescents and in boys. And most are unilateral, typically associated with some parenchymal disease. Thank you.
Thank you very much, Dr. Vu. It's amazing how much I learn every time I hear you give a presentation. So at this point, we're going to move on, and we're going to present some cases that we took care of right here in Portland. And if you had a chance to look at some of the images beforehand, you might have a little bit of a head start, because we are going to throw out, just for fun, some polling questions. And we will not know who you are, so don't worry about being embarrassed. Just throw an answer in, and it'll be fun. So before we start those cases, I just wanted to make a couple of comments. And the first is the amazing quality of most of those images that Dr. Vu showed. And while I wouldn't say that the images that I get here at my hospital are suboptimal, but I think a lot of times we see underpenetrated films, rotated films, poor inspiration films, and it is truly amazing what a difference that makes. And so can I strongly suggest that if you're in that situation where your films aren't a good quality, that you really insist that your radiology department gets you those images that are going to make the difference for the child. So that's the first thing I want to say. And the next thing I want to say is when I worked in California in the 1990s and the early 2000s, there was a lot of pediatric tuberculosis associated with that epidemic that started in the 80s in the United States. And so oftentimes when a patient came to my attention, they in fact had tuberculosis, and in many ways my job was easier. But now in Oregon we have so little tuberculosis that most of the kids who come to me someone asks the question, is this tuberculosis? And most of the time it's not. So even though Dr. Vu showed you all those beautiful films that turned out to be tuberculosis, you know, I think we really need to be careful that we scrutinize these cases carefully, especially when there's no history of TB exposure. Maybe there's not a positive skin test or a positive IGRA test. And so oftentimes, especially if a patient is not particularly symptomatic and there's not strong supporting evidence to make me think, oh, there's a good chance this is tuberculosis, sometimes what I do is I monitor the patient without any TB therapy for a few weeks if possible, if they're not going to get lost to follow-up, and again, they're not particularly symptomatic, and then I repeat an x-ray, because many, many times, whether it has to do with technical difficulties with the film or just the fact that maybe they had a viral illness, a little reactive airways disease, oftentimes the film's normalized and we save a lot of trouble. The next thing I want to just comment on is the fact that Dr. Vu showed you some beautiful CT scans, and we have a few CT scans in the cases that I'll show you. But many of you know this, but in case you don't, CT scans are rarely necessary for the diagnosis of pediatric tuberculosis. So the times that I wind up obtaining CT scans are usually is when there is something else in the differential diagnosis. So sometimes it's an immunocompromised host, and I'm asking the question, do they have a fungal infection or a malignancy? And so typically we do not obtain CT scans. When you look at the history of diagnosis of pediatric TB in the United States, really our diagnosis is based on plain film radiograph. And to that end, you know, essentially all children who have a TB infection early on are going to have some enlarged lymph nodes. And if we obtain CT scans on what's otherwise normal chest radiograph, we may overdiagnose those findings. So really think twice before you order a CT scan, because you may see something more than you wanted to. But if you do need to obtain a CT scan for the reason of looking for tuberculosis in a child, a big thing you're looking for is adenopathy, and in order to do that, you need IV contrast, which in many hospitals is a challenge because of requirement for sedation. Okay, so with that, we're going to move ahead, and this is the way that we sort of structured this. We are first going to show some x-rays. So, for example, right now you can see case number 6, and you see a little bit of information about him. He's an 11-year-old boy emigrating from Chuuk, which is an island in the Federated States of Micronesia. Chuuk actually has a good number of islands within their island state as well. So he comes to care for a tender mass on his thigh. And so the way that we have this structured is we're going to ask you to take a look at the image. We're suggesting that you think about it. And in this case, we're going to ask a polling question early on. So here is the lateral film for that. And we're going to give you a polling question. And that's coming up now. And this question is a little visceral. What is your gut reaction to these images? So I'm not sure, did we explain how to do the polling questions?
Not yet, no. They can just go ahead and click anywhere to vote.
Okay, so it's obvious to them. So the choices here, OMGG, that stands for oh my goodness gracious. If this is TB, it's not going to be pretty. I saw a lot of my friends' names on the participant list, so you know that I'm silly. B, if it's anything else, it's not going to be pretty. And C, I'm glad he's moving to Portland. Those are your 3 choices, just to introduce us to the polling questions and make you not embarrassed. So we have 200-some people participating, and right now we're up to about 100. We'll just give it a few more seconds since this is just a silly question anyway. And a lot of people say if this is TB, it's not going to be pretty. So we're going to end the poll. Thanks for participating. And we're going to view the votes. Oops, I guess I didn't want to do that. Sorry, guys. All right, so now I want to go back to the images. Thanks, guys. Okay, so when we originally put these slides together, we gave some of our friends from Los Angeles County who had originally requested some training in pediatric TB radiology if they had any questions just based on those images. And they asked about lab tests, and so his white count is 24,000. He has 83% neutrophils. His hemoglobin is 8.3, and he did not have SED-rate or CRP obtained. So at this point, we're going to ask Dr. Vu to share with us the interpretation of these films.
In looking at the frontal chest radiograph, first of all, the first thing you want to do is look at the cardiomyocyte silhouette. You can see that at this age, at 11 years of age, the upper, sorry, I keep forgetting to use the arrow, sorry about that. So look at the trachea and look at the cardiomyocyte silhouette. So in this case, of an 11-year-old boy, the upper mediastinum should be fairly narrow. And you can see that there are bulbous tissue expanding from the mediastinum. In the hilar region, again, the vessels are very bulbous as well, suggesting adenopathy. The heart is, the cardiac silhouette is fairly normal in size. Now, if you go to the lung, you can actually see opacity in both lungs. So this patient had finding consistent with adenopathy and consolidation / atelectasis in both lungs. Let's move to the lateral. Oops. Sorry about that. Okay, so on the lateral, so this is where we want to confirm adenopathy. The trachea is coming down. Normally you can see the right upper bronchus. So to the right of that, you should see the right pulmonary artery and the left pulmonary artery. Now this is way too dense for pulmonary artery. So again, this is consistent with adenopathy in both hilar regions. And then anteriorly, you can actually see consolidation overlying the region of the lingula on the left lobe, left lung, and the right middle lobe in the right lung, as well as some opacity in the lower lobe as well.
Thank you very much. So I see a great question in the chat area, and so I'll just tell you a little bit more background story. So this guy, I told you he's 11 years old. He's emigrating from Chuuk, but in fact he had stopped in Honolulu on his way, and he wound up in the hospital there at the pediatric hospital. And his story was that he had 2 weeks of cough and rhinorrhea in addition to 1 week of fever, malaise, anorexia. So hence why he deserved a chest radiograph there. And then this leg mass that he had was actually relatively new. So the pediatric ID doctors there, who are actually world famous, cleverly collected specimens, and they wound up obtaining this CT scan because there was a broad differential at this point. I mean, I think, I've been doing this for over 20 years, and this is the first leg mass that I've seen with tuberculosis. Interestingly, he had many cultures positive from many sites, and fortunately he had pan-susceptible TB, which, by the way, is not always the case in Chuuk. And they called me shortly before he was ready to come to Portland, which was his ultimate destination. And he had a fever and weight loss. They wound up treating with TPM. He was so ill for a full month in the hospital in Honolulu. So these are the CT scans from Honolulu.
And you want me to go over the images?
If you don't mind.
Not at all. Okay, so this is the same patient, and once again, within the mediastinum, this is the ascending aorta, descending aorta, and adjacent to this normal structure is large area of very low density structures. These are consistent with necrotic adenopathy. So the findings are now X-rays confirmed on the CT. And then in the lung window, you can see consolidation in the right middle lobe, and as well as the left lower lobe / lingular region. Once again, the differential is very broad still, even with the CT. Although anytime you see necrotic adenopathy, TB is in the differential, but as is fungal infection and metastatic disease, that's dependent on the patient's age.
Yeah, I would agree with that. Whenever I see that kind of inhomogeneous look to those necrotic nodes, in the context of asking the question, is this tuberculosis, it makes me think of that kind of infection, the caseating granulomatous infections in particular. Yeah. So the film on the left there is his first film, and then this film on the right is after 1 year of therapy. Fortunately, he clinically just did amazingly well after a very rough first month of treatment, which it wasn't quite sure how it was going to play out. But what do you think of that completion of therapy film, Dr. Vu?
Oh, wonderful. Great results. Just to compare the mediastinal structure, he looked like he's moving toward his normal mediastinal structure size as compared to the X-ray before. You can see that most of the adenopathy has regressed, and then the consolidation is focused on near resolution. So it looked like he had a wonderful response.
And in case I don't say this later, just a reminder that we treated him for a full year. He clearly had disseminated tuberculosis. But oftentimes when we are treating kids for only 6 months, their x-rays are not normal at the end of therapy. Normally it's just the lymph node swelling residua that takes the body a long time to clear out. Sometimes the atelectasis, the obstructive type phenomena. So we treated him for a long time. Okay, so this is our next case. And again, same thing, I'll just give you a little bit of introduction and ask you to think about it, and we'll do a polling question and then get you a little more information. So this is his frontal view, and the story was on this day, he was sent to me because the public health department got wind that his mother may have tuberculosis. So that's all the information that I had at that moment. Take a look at the frontal. And when we're talking about pediatric TB, we always want you to insist on a lateral film, especially for the kids under 5, but really ideally all kids, because as Dr. Vu told you, that really helps you understand whether there may be lymphadenopathy. So on the left is the chest radiograph that was obtained coincident with that first frontal view. And it turns out that 5 weeks earlier, he had had a PCR-positive viral bronchiolitis, and that's the right-hand lateral. So now you see a comparison. So at that time, his tuberculin skin test is 0 millimeters in duration. So this is our next polling question. I'm going to show you this frontal one more time and the lateral. Excuse me. And what the polling question is going to say is, what is the likelihood that this is tuberculosis? So the history you have is a vague rumor from the county jail that the mother may have tuberculosis. And this is the child's symptomatology and history of recent bronchiolitis and skin test negative.
Mm-hmm.
So it's very fun watching people vote. And interestingly, this distribution of votes, I think you can see it shows that more than half of people think it's kind of 50-50. So what are the things that make us think it's 50-50? First of all, this is an Oregon child, not a lot of tuberculosis in Oregon. The history has not confirmed that the mother has tuberculosis. The child's skin test is 0 millimeters in duration. And yeah, so not entirely clear. So unfortunately, that means I have my work cut out for me. Again, we asked LA County if they had any questions, and their questions, again, they're interested in lab work. White blood count was 8.8, 10% neutrophils. I just will say that really there are no lab tests that really help me decide if someone has pulmonary tuberculosis in terms of sed rate or inflammatory markers. I had a child one time who had TB meningitis, and his kidney was filled with tuberculosis, and he had a sed rate less than 10. So I don't think it's that helpful. All right, Dr. Vu, what do you think about these films?
Okay, so let's go back to the frontal chest radiograph.
Here it is.
It is great.
All right,
okay.
So I think I'll let you guys move the films.
Yeah, no problem. Okay, so again, you can see that the upper mediastinum is fairly prominent, but this is okay for a patient this age. In the hilar region, you can see that there are hilar opacities that, again, does not taper like a vessel. So the suggestion of adenopathy, at least in the right hilum, as well as maybe some atelectasis consolidation in the right lower lung. In the retrocardiac region, you can see that there's dense consolidation in this region as well, because it's obscuring the normal branching vessel from the hilum. And then within the left lung, tough to tell, probably okay, maybe some vagopacities, but probably okay. Let's move on to the lateral. So here's the study 5 weeks earlier. So on this study, you can see that there's maybe a little bit of atelectasis posteriorly in the superior segment of the lower lobes. The lungs are fairly hyperinflated because of a flat hemidiaphragm. Again, that can be consistent with both actually, bronchiolitis usually, but with TB you can also see hyperinflation, particularly if the airways are involved. Now, let's look at the lateral when the patient was seen for evaluation of TB. You can see that there are a dense area overlapping the right PA region. Now, this is way too big for a right pulmonary artery in a patient this young. So this is likely representing adenopathy. And then posterior to that, you can see that there's consolidation opacity involving the superior segment of lower lobes, as well as in the lower lobe, further in the basal segment of the lower lobe. So again, this is consistent with some type of infection. I think a repeated bronchiolitis event, I think, is unlikely because of the consolidation and the adenopathy. And so, again, the differential includes TB and other infections as well.
Thank you. And I see a couple great questions in the chat box. So the child was 5 months old when I first met him. And in terms of the mother, she had just very recently been incarcerated. So she had been taking care of her kids previously. So that's to answer those questions in the chat box. So what did I do for this kiddo? Well, it's what I always do when I'm asking the question, is this tuberculosis or not? So if I think there's a high enough likelihood that it's TB, I obtain gastric aspirates. If this is not something you're used to doing, we have a video that you can link to from our Curry website, which gives a video and also some distinct instructions. Just remember that gastric aspirates, what we're looking for is to collect sputum that the child has swallowed. So the child has to be NPO for a while, otherwise the stomach acid's empty. And it's a very low inoculum process. So there are not very many organisms in that sputum, which is pooled in the stomach. And so oftentimes the culture is negative. So 50% is generally a good yield. In a young baby, like a less than 6-month-old, it's a much higher yield. Again, this child was 5 months of age, but it's almost never smear positive. Smear positive happens when there's about 10 to the 6 organisms per mil or more. So please, please, please do not expect smear positive. Don't make any changes based on the smear negativity. And even if it's gastric aspirate negative, then you still have to kind of think about what's the likelihood of TB over time. And regarding the question of TST or quantiferon or IGRA test negative at the beginning of TB therapy, as people are mentioning in their in the chat box, you're exactly right. Many, many children will have a negative skin test or a negative IGRA, especially at the beginning of TB therapy. So at least 20%. And even a few of them will stay negative, even if culture positive over the course of time. So we like to say that a negative skin test, negative IGRA test does not rule out TB disease. And it's just one of those things that sort of helps us over time. So what I do in my practice is I assess all these pieces of information: clinical situation, radiographic information, demographic information, exposure risk, TST or IGRA, and then I make a decision about whether to treat the child or not. In this case, it turned out to be quite challenging to decide if the patient had an exposure, and I see that some of my friends from Washington County are here on the call. What happened is the mother was actually released from jail before they could finish her therapy. So she wound up having a positive quantiferon, but she did not get a chest x-ray, and she was back on the streets. So she did have a positive quantiferon, which is generally a pretty specific test. We have reason to think she had TB exposure. The kids lived with her. Does that mean they had a TB exposure as well? And in terms of symptomatology, what we understood is that she had her chronic, quote-unquote, smoker's cough, but no other new symptoms. So we really didn't get a lot more information, and even to this day, this was over a year ago, even to this day, we've never had any confirmation about mother. Well, maybe Washington County has. So what I chose to do is started him on 4-drug RIPE therapy for TB. Unfortunately, he worsened in terms of his clinical symptomatology. He wound up hospitalized. He had a new virus. He actually wound up in the pediatric intensive care unit. CT scan was obtained. He did have opacification of posterior medial lower regions of the upper lobes, right greater than left, and very, very nonspecific changes. So over the course of treatment, his quantiferon and his skin test remained negative. And let's see. That's the CT scan. I told you we don't always, we try not to avoid. We try not to do CT scans, and here we're showing you CT scans. And this is over time, his chest radiograph, this, see if I can pull this arrow over. So this fullness that Dr. Abu was showing you certainly improved. His radiograph improved over the course of the 6 or so months of treatment, and we truly can't know whether he had TB or not. In my practice, what I tend to do is I try to be very careful about not starting TB if there's not a decent likelihood that they have TB. And once I start TB treatment, I'm pretty much committed, because whether they had a viral process or community-acquired pneumonia, their chest radiographs are going to normalize. And if they're on TB treatment, we always can't necessarily determine which is which. So this is a tough case and is not that uncommon in an area where there's really low rates of TB disease. Okay, so so someone says, what was the right answer? 20 versus 50 versus 90? I think probably 50%. 50% chance in the beginning. All right, we are on to case number 8. Take a look at this. This is a 3-month-old girl, and she was identified somewhat belatedly during a contact investigation of a potentially contagious adult. So we're going to give you a little minute to look at that, and while you look, I will tell you that she is born in the United States in suburban Portland, Oregon. Her parents are also from Micronesia. They're also from Chuuk. We have a lot of Chuukese immigrants here. She was referred because a roommate who used to live with the family was diagnosed a handful of weeks before, and just over the course of time, they slowly divulged more and more contacts. So this old roommate was diagnosed with 4+ smear-positive tuberculosis. The baby was evaluated appropriately, had a skin test and chest radiograph done simultaneously, which is my strong preference, because as we talked about in the last case, the skin test may or may not be positive. We never would wait for a skin test to make more evaluation. So that's the child's frontal view. Here is a lateral view. Move that arrow out of the way. Take a look. See what you think. When I examined the baby, he had some work of breathing. I could literally hear no breath sounds on the right side in the front, and only minimal breath sounds in the back on the right side. So can we ask Dr. Vu to comment on these films?
Absolutely. Thank you, Ann. So on the frontal chest radiograph, you can see differential in lung hyperinflation between the two lungs. The right lung looks a lot bigger than the left lung. The patient may be rotated a little bit, but still the right lung appears much larger and more lucid than the left lung, suggesting maybe some air trapping in this young patient. In this case, when you evaluate the hilum, again, the hilar structure is not normal in that it doesn't taper like it should. So again, it suggests that there may be adenopathy on the right side, and maybe the adenopathy also cause some stricture, not stricture, but some narrowing of the airway, and hence the air trapping seen on the in the right lung. There's also opacity in the right lower lobe, as well as a little bit in the right upper lobe. Again, those could also be atelectasis or collapsed lung in this setting of airway compromise. Let's look at the lateral. So here's the lateral. Once again, you can see that the airway actually is tapered very narrowly. Here's your right upper bronchus, and surrounding it, you can see increased opacity, obscuring actually the right pulmonary artery, suggesting adenopathy. In the subcarotid region, also there's some adenopathy. So lots of adenopathy may be compromising the airway, causing air trapping in the right lung, and then in the right. In the lower lung region, you can see some atelectasis consolidation that was seen on the frontal chest radiograph on the right side. The upper lung, I'm not seeing much, maybe a little bit here. Okay? Go ahead, Ann.
Thank you. So this is an important teaching point for people who don't take care of a lot of tuberculosis, and I assume a lot of people on the call do take care of a lot of patients with tuberculosis. But just a reminder that when you identify an adult or teenager, adolescent with potentially contagious tuberculosis, you have to very aggressively evaluate the household and the household type contacts, but in particular the children less than 5 years of age, because those kids increasingly at risk as infants and less so as toddlers, less so as preschoolers, and then in the school age years minimally, but are at much higher risk of developing TB disease once they're infected. So we do what's called the contact investigations, and we want to prioritize those youngest kids. So in addition to the skin test or IGRA test, the chest radiograph, you also want to obtain a good history and physical exam, because sometimes the chest radiograph alone doesn't help you. And you want to also read that chest radiograph as soon as possible. Again, the highest risk of TB disease is in the youngest babies. We like to say that if you're less than 1 year of age and you breathe in the TB germs, you have about a 40% chance of developing TB disease. And again, that's in contrast to population as a whole, where adults may have a 5 to 10% lifetime risk of TB disease. So again, this child, 3 months of age, very high priority in this contact investigation, and evaluated exactly correctly with skin test right away, chest radiograph, and referral for more aggressive screening. So in history, it turns out that the baby had some tachypnea, some retractions for a couple of weeks, and the parents reported night sweats. Of course, many babies sweat when they're sleeping anyway, so that's a little bit hard to interpret. The family noted that baby was warm to touch and had noisy breathing, which was new. Mom reported that the baby had just developed a cough just prior to me seeing them, and otherwise she thought the baby was pretty well with normal eating, good energy, but had been sleeping restlessly. When I examined the baby, I mentioned that really in the front I could not hear any breath sounds on the right side. Baby did have work of breathing, especially sleeping, had retractions, had audible wheezes, especially with excitement, and the liver and spleen were easily palpable. So I can't remember if I have some more films here. Oh, I guess not. So we collected gastric aspirates on this baby, and they were positive for MTB, and this one was actually smear positive. And as I mentioned, the youngest babies have the highest yield with their gastric aspirates, and might even rarely, I mean, maybe in my career 5 times, I've seen a child have smear positive gastric aspirates. And as Dr. Vu mentioned, I was very concerned about that right-sided chest, both how it appeared radiographically and how it sounded on exam, and I was very worried about the phenomenon of air trapping. We sometimes call this the ball valve phenomenon. So if you have a lymph node that's compressing the airway, sometimes during that process air gets in, but it can't get out, and you get the hyperinflation. So there's a handful of indications for the use of steroids once TB treatment is underway. One of them is symptomatic TB meningitis, one is TB pericarditis, and the other is endobronchial tuberculosis in pediatric patients. There's evidence basis to use corticosteroids. So in this case, after I gave perhaps 2 doses of TB therapy, I started corticosteroids. And when you do this, you wind up needing to use steroids over sort of an asthma-type dose, 2 milligram per kilogram of prednisolone per day, and then wean over many, many weeks. So this is how the film progressed. And I'll ask Dr. Vu to comment on the 2 months into therapy.
Thank you, Ann. So this is the original film, and this is the follow-up study 2 months later. And you can see that the right lung is not as loosened, and the volume is more normal than before. So suggesting that the air trapping has somewhat resolved. I still can't explain this opacity up here. I mean, I've seen it previously. It's not as dense as now. I mean, I suppose it could reflect some lung atelectasis, and now the atelectasis had gotten more dense, meaning increasing atelectasis, and maybe that's why you're seeing that. The right lower lung area also improved. And the right high lung definitely smaller than before. So again, the X-ray suggests that the patient is responding to therapy.
And clinically, she was also responding to therapy. So even several weeks into therapy, just gradually I could hear more and more breath sounds on the right side. She was gaining weight, her temperature resolved, and she just did amazingly well. Just remember, if you're in this situation where you're using corticosteroids, ideally you're doing this with the help of someone who does a lot of pediatric tuberculosis. And remember that sometimes as you come off the steroids, you can have a flaring of the the reconstitution, and things can get worse, especially in the case of meningitis or tuberculomas. Fortunately, we did not have that problem with her. She just absolutely thrived, and her mom was just amazing at giving meds. So that's the good news. Here is her X-ray at the completion of therapy. I think it's pretty normal. What do you think, Kai?
Absolutely. It looks very normal. I mean, lungs are clear. The area in question previously are all resolved. I mean, the high lung is demonstrating normal branching vessel. There's no atelectasis consolidation in the medial rapid lung or the right lower loop. So, and then the lateral shows it all. Clear lungs, normal airway, normal caliber airway. Right pulmonary artery is normal size. Left PA is normal size. Subcarinal, no evidence of adenopathy. So, look like a complete response to treatment.
Yay! All right. Here's case 9, and this girl's situation was, for immigration screening. So she was her family was from Burma, but I think actually she spent most of her life in Malaysia in the refugee process. So we're going to ask all of you to look at this X-ray, and then we're going to do another polling question, and we're going to ask you to interpret that film. So I'm seeing mediastinal hilar concern and dabbling of other things. Dr. Vu, what did you think of that image?
Okay, let me go back to the, 1 second. Okay, so on the image, the thing that the lung looks fairly normal, the bony thorax looks fairly normal, but the right hilum look a little bit irregular to me. It doesn't have the nice taper like I've seen with normal vascular structure in a patient this age. So again, maybe mild adenopathy on the right side, but other than that, fairly normal looking study, no cavities, no small nodule that I can visualize.
So this was a really, really tricky situation. And so her story was that she, there were some of these subtle abnormalities on her chest radiograph that were not too excited. She was started on INH monotherapy. People didn't think she had TB disease. And right around that time, she developed a rib tenderness. She remembered having run into a doorknob, and the area stayed tender and then became increasingly swollen. So she wound up having a series of x-rays, let's see, and she wound up having a CT scan. What do you think of that one, Dr. Vu?
Okay, so on the axial soft tissue image, anterior to this rib, you can see an area of fluid density and perhaps maybe a little bit of rib enhancement around it. On the coronal image, I think inferior to the rib, you can see an area of round fluid density with maybe rib enhancement. So to me, it suggests there's a fluid collection that is inflamed, possibly infected, or possibly, since he ran to the doorknob, it certainly could be just evolving hematoma. I guess that would be my primary diagnosis, and then if not, if that area is really inflamed, the skin's really inflamed, then I would consider some kind of infection or inflammation associated with this rib. The rib itself looks fairly normal. I don't see evidence of fracture on the rib itself, but just an area of soft tissue abnormality adjacent to that rib.
This, unfortunately, this projection isn't very good, but where the blue arrow is, if you could see this image directly, you could see that the the cortex of that rib is disrupted and like hazy, ratty looking. And so this was a very tricky situation. It turned out that she wound up going to outside emergency department, and with their limited English, she could not tell the ER staff that she was being evaluated for tuberculosis, but she had a fluctuant mass on her chest wall that was IND'd and drained and packed, and she was treated with anti-staphylococcal antibiotics, and then the mass came back, the fluctuants came back, and once again, the stuff was drained. It wasn't cultured. Of course, it wasn't cultured for AFB, and so when she came to my attention, she had already received 2 long courses of anti-staphylococcal therapy, even treating for MRSA, and had clinical failure. So I was concerned that this was related to the positive quantiferon, and concerned for some subtle abnormalities on the chest radiograph with some intrathoracic lymph nodes. We asked our surgeons to debride that chest wall, trying to see if it would grow TB or see if we saw granulomatous changes on pathology, and it did not grow TB. But interestingly, we collected sputum, and it did grow pan-susceptible Mycobacterium tuberculosis, despite really not having any significant parenchymal changes seen either on plain film or on CT scan. This made me somewhat suspicious because it was also right around the same time that another case had positive cultures. And so I actually made the lab look into whether there might be a contamination in the lab or anything else, and there was not. When it was genotyped, it turned out to be a strain that comes from that area of the world, and there wasn't any other patient in Oregon who had that strain. And so that was that was a good luck day that we were able to grow that on culture. And the reason that I chose this case to show you is this. If you think about the process when immigrants and refugees are screened for tuberculosis, they have a TST, or nowadays usually an IGRA test, and they have a chest radiograph. And it's very, very important to also evaluate for extrapulmonary tuberculosis. So these kids also deserve a history in their own language and a physical exam looking for extrapulmonary tuberculosis. I remind people that you can have tuberculosis in any part of your body, from your brain to your eyes, to your throat, to your lungs, to your pleura, to your bones, your joints, your genitourinary tract. TB really can be anywhere, and you're doing your patients a disservice if in the process of screening them you don't do a history and physical if your skin test or your quantiferon are positive. So this completely normalized. This rib pain resolved, everything got better, and she is a delightful, healthy young lady. And so here's our last case. This case has been the biggest challenge of my career. Excuse me. He's a 15-year-old boy who just emigrated in the last handful of weeks from Vietnam, and he actually had hip pain. So here is his chest radiograph. I don't think this arrow is here for any good reason. And you can take a look at that chest radiograph, and we'll have a polling question come up. I think this is our last polling question. Does this film help you manage this teenager? So a lot of people are saying only if he has other TB findings, symptoms, exposure, TST, IGRA, all great questions. So again, he had recently immigrated. He had no particular TB exposures. His parents and his brothers are QFT negative. And our LA County friends asked us about labs. The white count was 6.1, 59% neutrophils, hemoglobin 11.4. His sed rate was 46, and his CRP was normal. So Dr. Vu, can you take a look and interpret these images?
Absolutely, Ann. Okay, so on the frontal chest radiograph, the thing that strikes me is the heart silhouette is a little funny. So I'm not sure if the patient true cardiac apex is on the right, or if it's right-sided cardiac enlargement, and that this is more normal on the left. In any case, the hilar region looks fairly good. The vessel taper normally, and as well as branches normally, so there's no evidence of consolidation or ataxia in the lower lung. But when you look in the upper lung, it's a little bit tricky in that over the right first rib, you can see there's some linear, maybe a little bit nodular density overlapping the first rib and the clavicle. So the finding, there might be a finding there. When compared to the left, particularly, if you don't see that, see those findings. And then there's a blow-up image, and once again, I think you can confirm that there's some linear, maybe slightly nodular density overlapping the clavicle and the right rib. You know, in this location, you always have to worry about TB because of the where reactive TB tend to occur. So definitely that's in the differential. It could be old, certainly, but activity is indeterminate unless the patient has symptoms and such.
So when you would dictate this film, what would you have said?
I would say, I would describe what I see, and that to correlate with patient symptoms. If there is a comparison that I don't have access to, and if the referring team does, I would ask them to compare and see if there's any change. If there's no change, it doesn't exclude active TB. So still, I think the diagnosis will depends on the patient's symptom, and of course sputum if there's high concern for active TB.
Okay, great. So people are asking in the chat box what were the symptoms associated with hip pain that led you to suspect TB, and what else was going on with this guy. So what happened is that in backstory, he had been actually having some intermittent sort of back pain and maybe leg pain in Vietnam, maybe for as much as a year, but much worse after immigrating to the United States. He had no cough, no fever, no known TB exposure, but 10 months prior to admission in Vietnam, he had had cough and fever, which was a pretty bad illness. He had reportedly a normal chest radiograph at the time of admission, at the time of immigration, but we did not have access to that. So his hip pain was so bad that he came to the emergency department. The emergency room doctor talked to the rheumatologist, and he wound up getting a quantiferon in anticipation of potential treatment for arthritis. He had a hip imaging done. He had a plain film which showed narrowed hip joint, and an MRI which showed symmetric joint effusions, loss of articular cartilage in both hip joints, particularly in the left, which is the painful side, associated marrow edema along the side of the joints, and the synovitis suggested an inflammatory arthropathy with superimposed mechanical arthritic changes. And I will tell you, I did not share these images with Dr. Vu to comment on, because this whole piece of the case became very, very complicated, whether he had a autoimmune arthritis or whether he may have had tuberculosis, because of the positive quantiferon and those streaky little changes, asymptomatic in terms of his chest disease. Unfortunately, or maybe fortunately, he got treated with high-dose steroids for presumed juvenile idiopathic arthritis before the results of the quantiferon gold test were known. And I think we have a film that shows what happened after to his lung field after starting steroids. What do you think, Dr. Vu?
Okay, so let's see. So let me use your green arrow to make sure. So to me, on this FOX study after high-dose steroid, there's a suggestion of a small cavity here. And let's see, on the blow-up image, again, there is some suggestion of a cavity, although we could be faked out by overlapping lines. But I do wonder if the disease got worse when a patient got placed on high-dose steroid.
Right, and so when we had the first chest radiograph finding, and we were trying to evaluate whether his hip disease might have been related to the positive quantiferon, and my partner, who's on the phone call here, was managing this part of the case. So we asked our orthopedic surgeon to both aspirate the hip joint and biopsy the synovium, because the question of the diagnosis was so very, very important, whether this was tuberculosis or just autoimmune disease. We did not find any evidence whatsoever, either on pathology or on culture, that he had any tuberculosis in his hip joint. And lo and behold, his sputum grew, dun, 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 multi-drug resistant tuberculosis. So, and he's HLA-B27 positive. In all evidence showed that he had severe cartilage destruction, severe autoimmune arthritis in his hip joint, which would require immunosuppressive therapy. So it was quite a challenge to treat this boy's hip for his terrible arthritis and treat his multi-drug resistant tuberculosis. And on top of it, he was a new immigrant, really no English, and he pretty much had every toxicity that I've ever managed with multi-drug resistant tuberculosis. And at the same time, he had H. pylori disease. So we wound up having to do a gastrostomy tube in order to complete therapy. After his TB therapy was well underway, he underwent joint replacement of that hip, and he is completely pain-free from his hip. He wound up having 2 treatment courses for his H. pylori, probably complicated by his aggressive immunosuppressants, including eventually tumor necrosis factor. He wound up receiving as many as 8 different TB drugs for multi-drug resistant tuberculosis. So this is 9 months into his course of MDR therapy, it definitely improving. And then at the end of therapy, we always like to do a completion of therapy x-ray. And in his case, because I knew it would be difficult to manage and follow any changes based on plain film, I also obtained a CT scan after I told you don't do CT scans, and just for a new baseline, because of his likely need for at least several more years of immunosuppressant therapy, I wanted to know what it looked like in case he had recurrent symptoms. So I'm putting Dr. Vu on the spot because he probably hasn't seen these images, but what do you think of those images? Can you see with the not great quality what the radiologists were looking at?
No, it's great. So we have blow-up images of the region of interest here, and once again, the area where I thought there may be a large cavity, I think it's completely normal now. You can see normal branching vessel because you can, on the older study, you can see the wall of this cavity. There may be smaller cavity overlapping the rib structure as well. And then on the study after completion of treatment, again in that region, in the region of the ribs and then overlapping ribs and clavicle, again you can see maybe just a swiggle of lines here. So that's really good. And then the CT post-treatment, I mean, you can see a little bit of scarring on the left side, which we didn't really appreciate on the chest radiograph. But on the right side, you can see there's an area where it's maybe small nodule in the right upper lobe, as well as maybe a non-specific nodule in the right lower lobe, which we didn't see on the chest radiograph, so we can't really evaluate that. But still, clearly no cavity or small consolidation or anything like that in the right upper lobe. It looked like this is just post-treatment changes.
Right, and so that's what we're praying and hoping for. We're hoping that every single organism in his body is dead, and TB organisms, and we hope he thrives and has a great outcome as we took out his gastrostomy tube and are continuing to treat his arthritis. So once again, those of you who know me know I talk too long, and we are running low on time, but we're gonna answer some of these questions, and you are welcome to stay on the call as we resolve some of these things. So I'm going to scroll up and let's see. So we talked about the case from Chuuk who had the thigh mass. Why did he get a chest radiograph? He also had respiratory symptoms. And Sham from UCLA Harbor, sorry, Sham, was saying, just to clarify, inhomogeneous necrotizing mediastinal lymphadenopathy also warrants the consideration of cardia. Absolutely. Some other interesting things go on there. In children post-treatment, would you see post-inflammatory residua or scarring? Yes, and what I expect is that almost all of the kids will be almost normal by 1 year. So if I treat a child for 6 months and in the next 6 months I expect that they're usually just about normal. Question about how good are the gene expert results on gastric aspirates, and they're way better than smear but not as good as culture. So the help is that they are quick, and that's a good thing. My lab won't release the results because they're not FDA approved, but there is a fair bit of literature. Let's see, Nancy Torres says, if you saw an infant in a couple weeks after contact, he had a normal chest radiograph and a negative skin test, would you consider repeating the chest radiograph in 2 months or so along with the PPD, or would you only do a chest radiograph? And so if we saw an infant after exposure, had a completely normal chest radiograph, had a normal history and physical, and a negative skin test, we would put them on what we call window prophylaxis. Usually that's INH, but if for some reason you know that the source case is INH resistant, we would consider rifampin. And so then we would only repeat a chest radiograph at all if the child developed symptoms. If he was asymptomatic, I would not repeat a chest radiograph at any time. And then it's tricky about when to repeat a skin test in a baby. We like to make sure they're old enough to have a accurate immune response. So the CDC says you can start to trust the skin test at around 6 months. Sometimes I go later. Andrea Cruz TB expert in Texas has a good question. Says, Ann, we often do a lumbar puncture in young infants if there's a concern for TB. Given the relative lower reliability of a neurologic exam, and she is exactly 100% right. One of my partners asked me this exact question, and she says, did this child get an LP? And I will say I am remiss. I did not do an LP. And it is true. There is a decent likelihood that this child had TB meningitis, because in the early phases, the findings on exam are very, very nonspecific. And the sort of only explanation I have is that I wound up treating this patient with steroids as they would have for meningitis, and I knew that I would treat on the long side, but it would have absolutely been the right thing to do to treat, to look for TB meningitis. Another thing that people often do differently when you're treating TB meningitis is use ethionamide instead of ethambutol. When a patient is sick enough to be in the hospital, I often use an injectable drug. So should we take a couple calls if there are people still on the phone, and then we'll address the rest of these questions in an email later?
I'm flexible either way. If anyone wants to have the question now, we can do that, or we can do it by email.
Kelly, what do you think?
Yeah, if anybody would like to ask a question over the phone, you can press *6 to unmute your phone line, and then go ahead and ask. We'll pause for a moment. Okay, I would assume that all the questions went into the chat field for today, so we're all set.
So I think what we'll do is we'll sort of case by case answer these questions and then share them with everybody, because people have great questions about individual cases. There are not so many questions that are general. Most of them seem applicable to particular cases, so we'll go ahead and address those and then send those out by email.
Awesome.
So that concludes today's webinar. Before you log off, we'd like to remind you to complete the individual online Qualtrics evaluation, which you should have received in an email this morning. We ask you to complete that within 1 week, so by June 25th, next Monday. And as a quick reminder, for any group members who did not pre-register, please provide us with your full name and your email address by entering it into the chat window, or by sending an email to the Curry Center email at webworkshop.currytbcenter@ucsf.edu. Thank you for joining us.
And thanks to Kelly and Amelia.
Yes, absolutely. Thank
you,
you, Ann.
Thank you, Dr. Loeffler. Thank you, Dr. Vu.
You're
Bye,
welcome.
Dr. Vu.